Good morning, everyone. Wow, big room. So thank you everyone for waking up early and coming to our scientific session, abstract session 4. Some housekeeping items before we get going. Obviously, day 2, a lot of things on the schedule today. Some of the things to look forward to throughout the day include the fireside chat, the mock courses, the hernia Jeopardy, and obviously a lot of original scientific presentations. A lot of great sponsors supporting our event, our silver sponsors, BD, Intuitive, Medtronic, Pacera. So if you're around and see them, definitely just stop by the vendors and the booths. Um, Today's going to be the Hernia Olympics as well, so try to make time for that and go and support the individuals that are involved in that. So we're going to try to stay on time. There's a lot of presentations, a lot of good content to go over the next hour and a half. We're going to lead off with Dr. Barbara East, who's going to be talking about where have all the female surgeons gone. Thank you.
Thank you so much. My name is Barbara. I come from Prague, Czech Republic, and I have a huge imposter syndrome. So thank you for having me. I have some disclosures. None of them are financially related to the topic of my presentation. In 2022, the Czech Technology Agency launched a new grant program called Sigma. And applicants could only receive funding when they proposed some solution to protect the country's critical infrastructure from future threats. And despite the strong opposition from many of the people involved, we succeeded in convincing the grant agency and we got some funding. Feminization of healthcare has previously been identified by some of the most important political and academic bodies in my country as one of the most pressing problems in Czech healthcare. And Professor Veselka on the picture, heavily supported by the Academic Senate, was trying to push a law that would limit the number of female being allowed to study medicine. Fortunately, that law didn't get through. Our project does not seek to limit the career choices of women and girls. Instead, we focus on transforming the environment so they can work safely and thrive. This project was divided into several stages. I'm going to speak very shortly about each one of them. And there are some results that have already been published as the mentoring handbook. This is the first stage. It was an online survey performed amongst nearly 3,000 university students in general. And it showed that while medical students report high satisfaction and they find their studies meaningful, the data reveal alarming issues. Over half experience depression and anxiety. Third, face gender-based discrimination. Forestry students were second on the list with 20%. And some even reported sexual violence or other unacceptable behavior from the side of their teachers. We have then focused solely on medical students and ran a second round of surveys, which was combined with some qualitative research and individual interviews. Female medical students face significantly higher rates of discrimination, harassment, lack of support, and it all had a very alarming impact on their mental health and career and family planning. If we focus on sexism solely and its perpetrators, it's striking to see that not only doctors, but also patients, nurses, or hospital administration staff played a significant role in this. As you can see from these interview transcripts, harassment and gender bias are still very real issues in medical education. Students report sexualized comments during exams, inappropriate remarks, propositions during clinical rotations, and they're being steered away, systematically steered away from certain specialties just because they're women. Female students face pressure to choose gender-appropriate specialties and are very often belittled based on their appearance or gender. At the same time, male students are often favored by the faculty, and these biases are heavily reinforced by both peers and instructors, highlighting persistent cultural inequalities in our education system. We also conducted 3 in-depth audits examining employee satisfaction, productivity, and management styles. My own department was one of them, so we had to frame this part as examples of good practice just to obtain approval for the study. And despite all three departments operating side by side in the same hospital, the slide clearly illustrates how leadership style and culture shape our workplace. Alongside our other work, we surveyed doctors who hadn't completed their specialized training yet, using both questionnaires and in-depth interviews. The findings are consistent with what we've seen elsewhere. Women report lower respect, support, and recognition. All trainees experience high emotional strain, heavy administrative burdens, and lack of guidance, but also unequal treatment makes it very hard for some to complete their training successfully. Breaking down these negative events, it's clear that the hospital workplace culture has a major impact on personal well-being. Seeking mental health support is stigmatized, and young female doctors often face condescending and dismissive behavior from senior staff. That is frequently used to reinforce compliance with unethical or even illegal practices. Our findings mirror what's seen in other fields and countries. Persistence in medicine often becomes a matter of survival, enduring harassment, coercion, emotional strain. Fitting in requires conforming to hierarchical norms and tolerating inappropriate practices, leaving women lacking both safety and sense of belonging. It's extremely difficult to feel the same sense of belonging in an environment like this. And I will never forget when I had a hand injury and I was told by one of my colleagues that it happened because I didn't stay in the kitchen. This pervasive bias shapes how we perceive ourselves and how we perceive our abilities. Repeated messages that you're less capable, combined with condescending on sexualized treatment, can seriously undermine your confidence, unless, of course, you're a psychopath. I will also never delete an email that I once received from my boss just after I had my second child that starts with, "Barbara, I'm not sure if you still remember how to read, but in case you do, this is my message." And again, a little reminder, this is not just a local Czech problem, it's global. And I know you in the room are probably the absolute wrong audience to listen to this, but I would like to thank you for being here. Despite all this, those who survive these challenges are by no means incompetent. Maybe they can not only perform surgery, but they can excel at it. But there are some other important differences between men and women. Men cannot give birth. Pregnancy and motherhood carry a significant burden, and I believe this should be celebrated by the society, not penalized. Children are our future, and everything else is a future of a different species. And this is a little psychological experiment to all the men in the room. Imagine if our roles have switched. Wouldn't comments like these suddenly feel really awkward? And also imagine you were giving instruments that were too big for your hands, or scrubs that just wouldn't fit you. Imagine being constantly corrected for being too this or too that, too little, too fat. Advice to change your voice and having professional work constantly sexualized. And how does all that previously mentioned affect our patients, our female patients? Maybe significantly. This is a picture Nadia Henriksen took at a faculty dinner in Copenhagen, 2021. Do you remember what she was taking a picture of? Or what these men were taking a picture of? Something they were proud of, something they allowed to happen. And this is Nadia taking that photo as the female faculty at a faculty dinner. Are there any two-headed gorillas on the slide? I don't think so. So I'd like to thank you for listening. And if you want to follow the project, it's a QR code that will take you to their homepage. Thank you.
All right, we're gonna do 2 minutes of questions for each presentation. So if you have any questions, feel free to come up to the mic. I'll lead off. Clearly, a lot of work to be done with regard to DEI initiatives. At your institution, are you doing anything to improve the current state of affairs?
Yes, our faculty became an application guarantor. So we're now running courses for everybody who teaches at Domenico University has to complete a course on harassment, gender sensitive communication and other things. And also all the department heads in our hospital have to complete an e-course on that topic.
That is awesome. Thank you so much. And thank you for talking about this very important topic.
Thank you.
We will move on to our next presenter, who is Ian Kim from the Beverly Hills Hernia Center. And he will be talking about, does a surgeon's specialty training affect their repair of ventral hernias? An analysis of 73,000 plus operations in the ACHQC. Sorry.
Good morning. My name is Ian Kim. I recently received my undergraduate degree from UCLA, and today I am presenting on behalf of Beverly Hills Hernia Center. Thank you for the opportunity for me to present our research titled, Does a Surgeon's Specialty Training Affect the Repair of Ventral Hernias? We have no disclosures. Ventral hernias can be repaired through open laparoscopic or robotic techniques. A surgeon's training pathway, whether in general surgery, minimally invasive surgery, or acute care surgery, may influence both operative strategy and patient outcomes. In this study, we used a large multi-center registry to examine whether specialty training affects three key domains: operative approach, quality of life improvement, or reoccurrence after ventral hernia repair. We conducted a retrospective cohort study using ACHQC database from 2013 to 2023. Over the decade, the ACHQC has collected data of over 73,241 cases after excluding incomplete records. We captured standard demographics such as age, sex, and BMI, measured preoperative risk using ASA class, and operative approach was categorized as open, laparoscopic, or robotic. Post-operative outcomes were included by recurrence rate, quality of life measured by Hercules scores, and pain levels. We also accounted for surgeon factors, including whether they practiced in an academic or private setting, and whether their training background was in general surgery, minimally invasive surgery, or ACS, which is an acronym for acute plus trauma surgery. For analysis, we used chi-squared, t-test or Mann-Whitney U-test, and z-test for proportions. Effect sizes were also calculated to highlight the clinical significant relevances of differences. Across the decade, general surgeons accounted for 56% of repairs, MIS surgeons accounted for 28%, and ACS surgeons came in lowest at 16%. Across specialties, most surgeons in the ACHQC practice in academic settings. About 64% of general surgeons, 67% of MIS surgeons, and nearly 73% of ACS surgeons practice in academic affiliations. The remainder come from private or a hybrid of private and academic affiliations. We calculated the effect size to analyze the significance of the differences, and the effect size came to be about 0.2, which indicates a negligible difference. Therefore, the differences in practice sites are unlikely to explain outcome variations. ASA class 3 and 4 proportions were similar across the three groups as well. MIS surgeons operated on slightly lower risk patients. Average age was about 56 years old. 54% of participants were male. Average BMI was about 32, and mesh use was overall pretty high at 82%. Operative approach distributions are nearly identical across the three specialties. Open surgery accounted for about 65% of the cases, robotic accounted for about 25%, and laparoscopic came in at 10%. Importantly, training pathway did not influence the overall distribution of surgical approach. At the 30-day mark, pain at rest was nearly identical across specialties. 37% of patients improved, 37% reported that their pain symptoms were unchanged, and 25% reported that their symptoms worsened. No meaningful specialty differences were observed. However, at the 30-day mark for pain during activity, there showed differences. Patients of MIS surgeons improved the most at about 77%, followed by ACS and GS. This aligns with clinical intuition as MIS patients often regain activity slightly faster. For moderate to major quality of life improvement, defined as a Hercules score difference of 20 to 100, patients of ACS surgeons led at 30 days with about 44% improving compared to 33% for general surgeons and 28% for MIS surgeons. This likely reflects the large early gains from treating acute impairments. By 6 months, however, the trend reversed. Patients of general surgeons showed the greatest improvement at nearly 63%, surpassing both ACS and MIS surgeons, which were closer to 55% each. At 30 days, recurrence was rare across groups, with rates nearly at 0%. By 6 months, recurrence stayed around 5% for general surgery and 6% for minimally invasive surgery, but was higher at ACS at about 13%. At the 1-year mark, ACS reached nearly 17% compared to 12% for MIS surgeons and 11% for general surgeons. Across the 3 groups, the practice setting mix is very similar, with similar proportions of academic and private practice. Preoperative risk is also comparable. Roughly half of ACS and general surgeons patients are ASA 3 and 4. The operative approach distribution is nearly identical across the 3 groups. Pain at rest improves or remains the same at about 66% at 30 days in every group, and 30-day recurrence is uniformly rare at under 1%. Bottom line is that core patient demographic and technical approach at the very earliest outcome at 30 days are effectively identical regardless of specialty. So where do we actually see separation is in specific outcomes over time. At 30 days, patients of MIS surgeons improve the most for pain during activity scores, while ACS patients see the biggest early quality of life gains. By 6 months, general surgeons patients show the most durable quality of life improvement. Recurrence follows the same pattern, lowest with GS, highest with ACS, and MIS in between. The take-home message is pretty simple. MIS surgeons gives the fastest functional recovery. ACS delivers strong early quality of life gains, but higher recurrence rates in the long term, and general surgeons provide the most durable long-term outcomes. These results reflect a specialized high-volume ACH-QC cohort and may not represent all US practices. Follow-up is incomplete, which limits the accuracy of the Hercules and recurrence rates, and may introduce non-response bias. Because this is a retrospective cohort study, we can't fully adjust for all confounding variables, such as patient history or hernia complexity. Therefore, results may not apply to non-ACH-QC surgeons. In short, operative technique was consistent across ACS, GS, and MIS surgeons. Differences in outcomes appear to be explained by patient acuity and case complexity, not by training pathway. Moving forward, prospective long-term follow-up and targeted protocols for high acuity hernias will be important, along with expanding participation to make these findings more generalizable. Thank you for an opportunity for me to present, and I am glad to answer any questions.
Thank you so much. That was great. Have you thought about if, you showed that all 3 of the modalities, open, laparoscopic, and robotic, were similar, but thinking that the MIS surgeons had a quicker recovery, possibly due to using minimally invasive techniques, have you thought about how you may be able to dive deeper into that?
Yes. We can analyze certain things like what kind of approach or what kind of mesh they use by specific MIS surgeons. So that can be done for future research.
Great talk. So with regard to the recurrence rate, clearly there's a huge difference between the groups, 17% at 1 year for recurrence in the ACS cohort. Is that are you excluding patients that are getting emergency surgery, or are those patients also included in that cohort?
Both elective and non-elective patients were included in the surgery.
Okay.
And to kind of add on a little more, we looked at operative duration, which was not covered in our presentations due to time constraints. Acute care surgeons had a very bimodal distributions. They had about like 43% were very short, and about 33% of their surgeries were roughly longer than 4 hours. So that, I guess, could account for how both elective and non-elective cases.
Yeah, as you work towards a manuscript for this, I hope using and excluding the patients that had emergency surgery so that we can really compare apples to apples would be nice, because there's a very different approach to hernia care in this acute setting. Nice job.
Yeah, thank you.
All right, let's move on to the next presentation. Next up is Dr. Catherine Cordero from NYU Long Island, presenting on hybrid versus robotic assisted abdominal wall reconstruction, a single center's technique and outcomes.
Good morning. Thank you so much for the opportunity. There you go. So we would like to thank the Society for the opportunity to present our work that is titled Hybrid versus Robotic Assisted Abdominal Wall Reconstruction, a Single Center's Technique and Outcomes. This is our team. For disclosures, only our PI have disclosure that won't affect this talk. For the background, we have that the use of the robotic assisted platform for hernia repair has taken off since the early 2000s. The surgical robotic technology has improved surgeons and patient outcomes. The RoboTAR has become a pretty standard approach for complex abdominal wall reconstruction. Limitations for robotic abdominal wall reconstruction approach include larger defects, need for extensive mesh explantation. Patients require that a scar revision or paniculectomy that would need an open approach, and the open TAR increase wound mortality, cost, and longer hospital stay. This novel approach combines the elements of open and robotic surgery to allow a hybrid approach to TAR, hybrid TAR, in selected patients. The objective is the evaluation of primary outcomes as length of stay, SSO, SSI, readmission at 30-day. Our secondary outcomes will aim to determine patient risk factors and hernia characteristics. And our hypothesis was that hybrid approach will replicate similar outcomes of robotic component separation and hernia repair. For the methods, we have a single center retrospective analysis. Patients with a primary and recurrent hernia repair by the single surgeon, RPI, were included. A robotic abdominal wall reconstruction and hybrid abdominal wall reconstruction performed between January 2015 to 2025 were included with the RB approval and the consents. The data was collected from the electronic medical record. So the statistical analysis was pretty much straightforward. In general, the descriptive statistics were presented as mean, median, or frequency as appropriate. For the technique, we would like to highlight that in the hybrid abdominal wall reconstruction, the axis, the lysis of adhesions, the dissection of the muscular planes for competent separation, and the mesh dissection, if applicable, is performed robotically. The posterior elements are closed robotically as well. The robot then is undocked and the abdominal wall incision is made. The remainder of the procedure is carried on in an open fashion. The mesh is positioned in the retromuscular plane. The anterior fascial closure is performed. The scar revision, paniculectomy, and resection of any redundant skin if needed, or the sac is performed. Use of drains are selective to each case, usually retromuscular and subcutaneous, and a Prevena wound bag is used. These are the results we got for the demographics. Our overall number of patients were 30 patients, and you can see that chronic obstructive pulmonary disease was definitely more prevalent in the hybrid abdominal wall reconstruction group, and higher ASA class 3 was also more prevalent in the hybrid abdominal wall reconstruction group. For the hernia characteristics, we would like to highlight that the hernia defect width was larger with 15.1 centimeters in the hybrid abdominal wall repair compared to the robotic group with 11.7 centimeters with statistical significance. Then for hernia characteristics, the defect width, the range we have in the hybrid abdominal wall reconstruction goes from 7 centimeters to 20 centimeters in comparison to the robotic abdominal wall reconstruction group that goes from 6 to 17 centimeters, with a larger hernia defect area in the hybrid abdominal wall reconstruction group. For mesh details comparison, we also have a mesh width mean higher in the hybrid abdominal wall repair and also a higher mesh area mean with 1,072 square centimeters in the hybrid abdominal wall reconstruction group in comparison to the only robotic abdominal wall reconstruction group. For drains, we would like to highlight that 100%, 13 patients out of the 13 had drains in the hybrid group, and this was statistically significant, with retromuscular in almost half of them and subcutaneous in all of them. For the robotic group, 35% had drains, 5 out of 6 had a retromuscular drain, and 1 out of 6 had a subQ drain. The post-operative outcomes that we have is that almost 43%, close to 50% of patients had a 24-hour stay or less in both groups. And also we had no readmission, no reoperation, no recurrence, and the SSO was only 10% overall, with a 15% in the hybrid group and 5% in the robotic group without statistical significance. For surgical site infection, there were none. Limitations of our study is that we have a small sample size. It's only a single surgeon's data. It's a single center study, and we only carried the 30-day follow-up for complications that we would like to extend, taking account of the quality of life as well of the patient perspective. For conclusions, we can conclude that the hybrid technique and the robotic technique for abdominal wall reconstruction show no significant difference in length of stay, complications at 30-day follow-up. Hybrid abdominal wall reconstruction allows for the repair of larger hernia defects requiring competent separation, which would otherwise not be amenable to a purely robotic approach, while also addressing the problem of skin redundancy or need for a larger mesh explantation. The benefits of a purely robotic approach seem to be maintained with the hybrid approach. We would like to thank you, and this is our PI contact information.
Thank you so much. My question is, if you know how many of the patients or what percentage had a paniculectomy versus other skin and soft tissue, like complex excisions, versus how many did you decide to do hybrid for other reasons?
So in the hybrid group, they were included either there was a sac resection, paniculectomy, or skin redundancy. They all had one of those procedures done in an open approach. And the mesh was put in an open fashion, secure in an open fashion.
So the driver for your decision between hybrid and straight robotic is the skin and soft tissue work?
Yes.
Okay.
Yes. For these patients that need like a larger mesh explantation or address the issue of the extra skin redundancy that cannot be performed
Yeah.
robotically, right?
My second question, I guess, would be, have you looked at this compared to straight open cases?
Have you what?
Compared this to like straight open cases, not?
No, because our PI is a minimally invasive robotic 100% surgeon. This is the most open that we have. Like open cases are very low.
I understand.
So
Okay. That would be interesting.
that's another bias, definitely.
Okay. Dr. Nicole.
So with regard to just a few more questions, in terms of patient selection, at this point in your practice, you are primarily focused on utilizing robotics to reduce length of stay. And with regard to these patients, they were prospectively planned to have a hybrid approach, or were some of these patients intraoperatively converted to a hybrid?
No, it's selective. It's an elective decision. When they come to the OR, that's the plan. Like it's not out of the blue. So that's the plan already preoperatively with the CT scan and the whole physical exam.
Thank you so much.
Thank you.
All right, next we have Dr. Sean McCarthy from the University of North Carolina. And he will be talking to us about anxiety and depression effect on inguinal and ventral hernia repair outcomes.
Hello, everybody. I just want to first thank the conference as well as our moderators for letting me speak today. So we were looking at anxiety and depression outcomes on ventral and inguinal hernia repairs. In terms of, these are disclosures, none of which are relevant to this talk. Now, anxiety and depression are becoming increasingly prevalent among Americans. And then over time, this is, of course, translated to general surgical populations. Previous studies have shown that those surgical populations have had higher rates of postoperative complications, as well as longer hospital stays and higher readmission rates. However, this has been not fully studied within the abdominal wall surgery population. There has been some limited data to show that patients with anxiety and depression have larger hernia sizes, as well as higher rates of wound complication. However, there has been limited data on randomized controlled trials, especially ones looking at patient-reported outcomes. These patient-reported outcomes are becoming increasingly used within the randomized controlled trials within surgery, and we thought that it was important to characterize these understandings, which is where we started our research. So we were looking at patient-reported outcomes amongst patients with anxiety and depression undergoing inguinal and ventral hernia repair, and we used the ACH-QC database. Within this database, our inclusion criteria are those who had preoperative anxiety and depression diagnosed and then underwent hernia repair. We used a 1-to-2 propensity score matching algorithm, matching for those various factors. When we were looking at the patient-reported outcomes, we used the Hercules scores for the ventral hernia repair, where a higher score is indicative of a higher quality of life. And then we also use the PROMIS T scores, which is a higher score indicates a lower quality of life. For our inguinal hernia repairs, we use the EURA-HS quality of life scores, where a higher score is indicative of a lower quality of life. Our primary endpoints of this study were 30-day complication rate, surgical site infection, as well as surgical site infection requiring procedural intervention, as well as some other secondary endpoints. Now, when we first looked at the ventral hernia repairs in terms of surgical site infection, we did see that there was one significant result of surgical site infection requiring procedural intervention. However, there was a limited difference between our groups, and we did not feel like this was clinically significant. Some other surgical site outcomes that we're looking at in the ventral hernia group, none of which were of statistical significance. And similarly for the inguinal hernia repair group, none of these were of statistical significance either. When we were looking at the patient-reported outcomes, however, we saw that there was a higher quality of life amongst the ventral hernia repairs by the Hercules scores, both at baseline and 30 days postoperatively, with significant p-values. Similarly, when we were looking at the PROMIS T scores for the ventral hernia repair group, we saw that there was less pain reported for the control group, both at baseline and 30 days. Now, for the inguinal hernia repair group, we were using the EURA-HS pain scores, and we saw that there was significantly less pain both at baseline and 30 days. And you're starting to see a pattern here, where in the restriction domain, we also saw more restriction at baseline amongst the depression and anxiety group. However, we did not see this at the 30 days post-op. Moving on to the aesthetical domain, we saw that there was overall no significant differences between our two populations at this point. And then overall quality of life, we saw that for the anxiety and depression group, we saw that they had lower quality of life both at the 30 days or baseline and 30 days postoperatively. In terms of the study, we were relying on reporting data, which was one limitation for us. And additionally, when we're looking at these patient-reported outcomes, there's no good data to say exactly how these are clinically relevant. And more research would have to be done in order to understand those differences. Furthermore, one limitation we had is that there is unknown, we don't know exactly the significance of treating anxiety and depression before surgery as well, and that's impact on some of these scorings and outcomes. However, when we are thinking about what we can gather from all this information, we saw that anxiety and depression are associated with worse post-operative or patient-reported outcomes after surgery, as well as them not being currently used in randomized controlled trials, which will be important in the future to incorporate mental health diagnoses as part of our research strategies, as well as when we're working inside of surgery and in the clinics. And that is it. Just want to say thank you. And any other questions?
Nice job. So clearly, patients' baseline impacts their post-operative outcomes as well. One thing that you may want to do in your future work is looking at the delta, the change from baseline to post-op, because where you start will dictate where you end up. What types of interventions do you think we can do in the clinic when we evaluate patients once we identify that they may be dealing with depression or other issues to improve their long-term outcomes?
Yeah, I think it's important to make sure that they have their depression and anxiety under control preoperatively, just like how we're controlling for smoking status and other functional health statuses, and trying to optimize them for surgery, especially when it's more of an elective setting. We have time to basically control that anxiety and depression, make sure that they are on the proper medications or getting the support that they need otherwise.
All righty. Next up, it's actually you again.
Yeah.
So Sean's going to be talking about mesh fixation. Is it necessary in retromuscular ventral hernia repair? A meta-analysis.
All right. So once again, just want to say thank you for letting me present on another topic that we were looking at. So we're looking at mesh fixation in terms of retromuscular hernia repairs. And for this study, we did a meta-analysis. Again, similar disclosures as the last one, none of which are relevant to this talk. So starting off, retromuscular hernia repairs were first introduced by Reeves and Stopa back in the 60s and 70s. And these are becoming more prevalent and more commonplace today with the addition of TARS and minimally invasive surgery. Now, during this process of mesh use, we were looking at, is mesh fixation actually necessary? There's two different schools of thought, one being the pro-fixation group saying that it secures the mesh, it allows for more enhanced ingrowth and prevents recurrence, whereas the group against fixation says that it increases operative time, increases pain, and has the potential for increased vascular injury. Studies to date have been have had conflicting results on which one of these paradigms is the best one. And additionally, the evidence specific to retromuscular hernia repairs is overall scarce. Where we started with this is we saw some new research showing that there is increased morbidity associated with the fixation of mesh without any decreased recurrence. There has been no systematic reviews to date of this, and that is where our research begins. For our inclusion criteria, we wanted to compare retromuscular hernia repairs with and without mesh fixation. And our primary exclusion criteria for this study was any overlapping patient populations that we could find. So overall, we screened for 764 different studies, and that was our initial number. And after our inclusion and exclusion criteria, we ended up with 6 total studies that met our criteria. These 6 studies, they were a mixture of prospective and retrospective studies with a total of roughly 15,000 patients within our group. When we first looked at the patient-reported outcomes, we looked at the Hercules scores at the 30 days post-operative, and we saw that there was significant better quality of life amongst the non-fixation group compared to the fixation group. Similarly, when we looked at hematoma occurrence rates within these two groups, we saw that those that underwent fixation had significantly higher rates of hematoma formation. Pain, on the other hand, was a little bit more mixed. We were looking at 5 different studies, and there was a lot of variability in terms of the reporting outcomes as well as how these scores were calculated. Now, we did look at the VAS scores, which showed that there was no difference in pain associated with the fixation versus non-fixation, both at the first day and 30 days postoperatively. And some of the other studies showed more mixed results. When we were looking at recurrence rates, we saw that at 1 year, there was overall no difference in recurrence rates among fixation and the non-fixation group. And then all of our other outcomes that we were looking at, none of those were of any statistical significance. I do want to point out, though, that for the operative time, though, there did seem to be a tendency for longer operative times, even though this was not statistically significant within our study. So overall, this study, we had a mixture of prospective and retrospective studies in our analysis, which obviously is not going to be the best for a full cohort, and we were limited in our data evaluation. Additionally, with our pain scores, we had difficulty with combining those different studies based on the different scoring metrics, as well as overall outcomes. Furthermore, there's a limited number of these studies that we were able to actually analyze. New research is coming out over the past few weeks and months, and of which we are still planning on putting that together in our final manuscript as well. So in conclusion, we saw that mesh fixation did not lead to any increased recurrence risk, depending on if you fixated or not. But if you did fixate the mesh, there was higher rates of hematoma formation, as well as worsened quality of life for the patients within that group. Further studies down the road can focus more on these long-term outcomes, as well as recurrence rates at the 1 year and 5 years down the road. And that is all I have to say about this topic.
Thank you very much. My question is, do you fixate your mesh?
So I am still a surgical resident. However, I think that is certainly something that I will consider in my practice down the road. I think that if you have good overlapping of the mesh, I think it is reasonable to not fixate the mesh. However, if you're in a difficult spot where not good overlap down near the pubis, I would probably consider more likely to use some fixation there.
Okay, please. Can we get hit? Sorry, we can't hear you, Dr. Sheen. Can you get his mic on, please?
Yeah, it's working now. Thank you very much. I really enjoyed your talk. I'm Ali from the UK. If you look at surface area and large hernias, if you have a large surface area, the mesh will just stay in. The intra-abdominal pressure will be great enough. Do you think there's a cutoff in terms of size and diameter where you must fixate the mesh?
I think as the hernia gets bigger, I think that there would be it would be reasonable to consider more fixation. However, we don't really have any data to support either way with that instance. And then my PI, Dr. Mazzola, would like to say something.
All right, thank you very much. All right, next we have Dr. Sean Cometa. And they'll be talking to us about multi-institutional outcomes for following novel technique, transabdominal preperitoneal ventral hernia repair with rectus abdominoplasty.
Thank you. All right, thank you all so much for the privilege of the podium. As mentioned today, I'll be discussing our multi-institutional outcomes following transabdominal preperitoneal ventral hernia repair with rectus aponeuroplasty. So while I have no disclosures, some of the authors in this study serve as consultants to the following companies. So in the last decade, there's been a significant increase in the utilization of sublay retromuscular mesh-based ventral hernia repairs. If you were at the Hernia World Cup yesterday, you'll recognize this graph. From 2013 to 2019, the rate of open sublay mesh utilization has increased from roughly 34% to 41%. Additionally, during that time, the rate of component separation, while a low frequency overall, has increased by a factor of about 50%. So contrary to these trends, there's an emerging theme among abdominal wall specialists that on preserving the retromuscular plane if at all possible. Excuse me. So in the setting of moderate to large size defects, many surgeons elect to utilize a retromuscular approach with myofascial advancement flaps to relieve tension on the anterior fascial closure. Our team has been looking at strategies to minimize the use of the myofascial release procedures. In 2024, we published a proof of concept paper on transabdominal preperitoneal repairs with concurrent rectus aponeuroplasty, or TAPRA, with favorable outcomes. Major advantages of TAPRA include offloading tension, utilizing extraperitoneal mesh placement, minimal need for penetrating mesh fixation, and closure of larger defects while primarily preserving the retromuscular plane, particularly near the semilunar line where the neurovascular bundles are. So the goal of this study was to evaluate the feasibility and reproducibility of TAPRA across multiple hernia centers. Before I dive into the our multi-institutional outcomes, I would like to sort of contextualize the TAPRA procedure. It starts with the traditional preperitoneal dissection and extends into a pretransversalis dissection. You can do as needed docking for larger as needed contralateral redocking for larger defects. We then do the rectus aponeuroplasty and fascial closure, with then mesh positioning and fixation, and then a standard preperitoneal flap closure. So this is a patient with a 4 by 6 centimeter incisional hernia at the extraction site after a cystectomy with ileoconduit creation, which you'll see in the background here. So for TAPRA, we start with the standard preperitoneal flap dissection. We try to recruit as much autologous tissue as possible, though oftentimes losing the central hernia sac. You'll notice that this is a somewhat smaller hernia as it was an earlier TAPRA case, but we've expanded our utilization to larger hernias. So here we're getting into the sort of extended pretransversalis plane, and here we're doing the rectus aponeuroplasty. You can see that as the posterior sheath retracts, it's offloading that tension. We then go with the standard defect closure, bringing the anterior fascia together with sequential tightening of the suture, and then mesh placement and sort of loose sutures, and then we close the peritoneal flap as standard in a TAP procedure. So in this multi-institutional study, we're grateful to have collaborators from OHSU, Dr. Vahag Nikolian, as well as from University of Alabama, Birmingham, Dr. Abhishek Parmar, and then from Stony Brook University, Dr. Artem Shmelev. In this, across the 3 practices, we reviewed 41 TAPRA patients with an average age of 56 years old and 51% male. You can see in the breakdown of comorbidities here, 22% of the patients had diabetes, 12% had a prior abdominal wall infection, and 12% were using tobacco at the time of surgery. As for the hernias, the large majority were incarcerated, many were incisional, and 15% were recurrent hernias. The average hernia width was 6.2 centimeters, and the average hernia length was 8.8 centimeters. In 7% of the cases, we were able to do a concurrent inguinal hernia repair utilizing that preperitoneal plane. The most common mesh used was lightweight macroporous mesh, an average size of about 20 by 20 centimeters, really highlighting that extended dissection. So post-operatively, about half of the patients were able to discharge the day of the operation. 82% of the patients discharged within 1 day of the procedure. So the rate of surgical site infection was 7%, all of which were treated with antibiotics alone. There was 1 surgical site occurrence, a seroma, that did require procedural intervention. As for other immediate postoperative outcomes, there was 1 pulmonary embolism, but otherwise no occurrences of the complications listed. And while the study was intended to understand the reproducibility and feasibility of TAPRA, I will tell you that there were no recurrences, though of course, with the short duration of only 60 days follow-up, this may not impress a lot of people. So the work here demonstrates that the TAPRA approach is safe, feasible, and associated with appropriate short-term outcomes for the repair of moderate-sized incisional hernias. As for future directions, of course, we need longer follow-up of these patients that underwent a TAPRA ventral hernia repair. Additionally, as we become more comfortable with the TAPRA approach, we've been expanding it to larger hernias, measuring 6 to 12 centimeters with the use of the double docking technique. I'll show you that here. So briefly, this is a patient with an 8 by 12 centimeter incisional hernia after a AAA repair. you can see a very extended lateral dissection where we essentially accomplished the same sort of dissection plane as seen in a transversus abdominis release. However, in this scenario, the muscle is not released to gain access to this plane. The dissection is carried into the retroperitoneal fat as well as the subdiaphragmatic space. After circumferential dissection on the left, we do the posterior sheath rectus aponeuroplasty. The mesh is then placed and fixated laterally prior to docking on the contralateral side of the patient. After the double docking, we then complete the dissection on the right side, as well as perform the right-sided rectus aponeuroplasty, which you'll see here. And then again, with standard closure of this defect with sequential tightening. Again, you can see that with the tension offloaded, the rectus sheath has retracted. And then we, close the peritoneal flap and then unroll the mesh. So with that, I would like to thank our collaborating surgeons, Dr. Nikolian, Dr. Bosley, Dr. Pramar, and Dr. Shmelev, as well as some of our hernia team members listed here. And I'd be happy to take any questions.
Great job. Thank you. My question is, how are you deciding when to use this versus doing a standard tap repair?
Yeah, I appreciate that question. One of the benefits of this TAPRA approach is that you can decide at the time of surgery. So when you're after doing your standard tap dissection, if you're feeling that there is undue tension when you're trying to close the fascial defect, then you could easily do a rectus aponeuroplasty. Of course, preoperatively, you may have concern if you're seeing a sort of moderate to large size hernia that's on the edge of what you would be comfortable doing a tap dissection for. If you're kind of considering, maybe I would do a rectus repair, but they have pretty thin rectus and I worry that I wouldn't get broad overlapping mesh coverage, then this would be a good option for that.
To kind of, I guess, ask one more question based on what you just said is, you're doing this to help close the defect though, right? Not to get mesh overlap, because if you compare it to tap, you can get this same broad mesh overlap, right? So I think the thing to consider is, yes, are you making the decision that you need to close the defect preoperatively often, or is it always kind of in the operating room and you are, decide that there's too much tension to close the anterior fascia, so I'm going to add this. And when you add it, do you always add it to both sides or do you do it unilaterally?
Yeah, great question. I would say the decision on whether to proceed with a pre-peritoneal mesh placement versus a retrorectus is done generally preoperatively. Of course, you could always get into the rectus plane, but if you were concerned about narrow rectus, then you would get into your tap pre-peritoneal dissection, and then if there is tension, decide at the time of the operation. And I believe generally we do it bilaterally always.
All right, thank you very much.
All right, next up is Dr. Vito Neves presenting on the impact of the socioeconomic status in hernia treatment, a qualitative systematic review.
To pass, just okay. So, thank you. Like you said, I'm Vitor Neves. I'm from Brazil. I'm from Rio de Janeiro. And I'm here today to talk about the impact of socioeconomic status in hernia treatment. We did a qualitative systematic review. First of all, I want to thank you, Diego Lima, for the opportunity to represent our entire group here. It's such an honor to be here. Thank you, Diego. I have no conflict of interest. Hernias remain one of the most common surgical condition worldwide, requiring timely repair to prevent complications such as incarceration and strangulation. Advances in minimally invasive surgery and robotic surgery have improved outcomes, but We know that the health systems does not treat the patients with equity. And I think that we need to try to do this. We need to do this because we want to reduce our complications. We want to improve our results and do all of this to, of course, to improve quality of life to our patients, to our community. So our study aimed to systematically evaluate the impact of socioeconomic status on hernia treatment and outcomes. We performed qualitative systematic review, like I told you before. We looked at 5 major databases, PubMed, Embase, Web of Science, Cochrane, LILACs, and we did everything with Prisma, guided by Prisma, following Prisma guidelines. We started with 116 articles, and after removed duplicates, and we did the screening and the full text, we included 22 studies. And we analyzing nearly 1.9 million patients, comprising different types of hernia. 10 studies about ventral hernias, 6 studies combined ventral and inguinal, 4 about incisional hernias, and 1 study about inguinal, and 1 about diaphragmatic hernias. Some of our results, we saw that high risks of complication, Nowitzki, show us that patients covered by Medicare and Medicaid present higher mortality, higher risks of fistulas, and longer hospital stays. Bowman also showed that patients with public insurance are more likely to present with more complex hernias, which can be more challenging to treat. And Sakowitz reported that vulnerable patients experience higher rates of perioperative complications. Tartarian demonstrated that these patients have reduced access to robotic platforms and consequently are unable to benefit from this type of treatment. We saw that white patients are more frequently covered by private insurance, and which allows them to access better treatment options. Some patients who lives far from large urban centers and in areas with limited access to the healthcare system, often delay their treatment and increasing the likelihood of complications. And of course, we also recognize that vulnerable patients usually present with more comorbidities, which may also be an important factor influencing treatment outcomes. Some limitations to our studies. Most are retrospective studies. We had 1 prospective. Socioeconomic status reports were different in some studies. And most of the data are from US. They may be not the reality in low and middle income countries, where barriers differ, like my country, for an example, Brazil, including worse surgical materials or surgical expertise. And long-term outcomes, like recurrence and quality of life. was also inconsistent. Our conclusion is the socioeconomic disparities significantly influence outcomes in hernia repair. So again, I would like to thank you for the opportunity, and I'm here for questions.
Thank you very much. Clearly, a difference in outcomes for patients in different socioeconomic statuses. What do you think is the driver? Do you think it's the techniques that are being offered? Do you think it's the perioperative care that's delivered? What do you think are the biggest drivers?
We saw that in our studies that it's a multiple variable. Of course, some points are related to the hospitals, some points are related to the material. Like I said, the surgical expertise in poor countries, maybe you don't have specialized in abdominal wall treatment. So complex hernias and big hernias are difficult to treat. And of course, patients who are vulnerable, they delay their treatment, and the cases are more complex when it came to the surgeon.
Thank you very much.
Thank you.
Next, we have Dr. Tushar Mishra, and he'll be presenting on the self-fixating mesh versus tack fixation in TEP inguinal herniaplasty, a double-blind randomized control trial.
A very good morning, all of you. I'm Dr. Tushar from India. So today I'll be talking about my study, the self-fixating mesh versus tack fixation in TEP repairs, a double-blind randomized controlled trial. We call that the self-tack trial. I have no disclosures. So if you see annually, more than 20 million groin hernia surgeries are done worldwide. The faster recovery and the less postoperative pain makes laparoscopic inguinal hernia repairs an obvious favorite. Mesh fixation is considered important to avoid recurrences, and tackers are the most common form of fixation that's being used, but it has a cost and also is associated with higher inguinal. The European Hernia Society guidelines are pretty much clear that almost all of the hernias do not require any fixation whatsoever. Only the large direct hernias, the M3 type, would require some form of fixation. And if at all we are fixing, then we should be using the non-penetrating or the most automatic types of mesh fixation devices. So after this guidelines, does this study hold any relevance whatsoever? Well, if you see, fixation devices are still being used across the world. If at all we are fixing for whatever reasons, be it a TAPP, be it a TEP because the surgeon is choosing one, or be it ETEP, or a large groin hernia, we need to know what is the best method of fixation. This is just a recent publication in the hernia by the Danish Society. And what we can see is that they have seen that non-penetrative fixation devices are preferred. There has a lesser chances of a research surgery, and the self-fixating mesh being the most favored. But we had apprehensions regarding the particular type of mesh. Can we deploy it easily? Will there be any complications? Is there a good learning curve which we can do? Till that point in time, only this large retrospective study was there with 780 meshes, wherein the fixation was tried, but there's no RCT for which they said that it is a reliable mesh and could be safely used. So we had the aim of studying the safety and the feasibility of this mesh in TEP repairs, with the study hypothesis being because we are not using a fixation device or any penetrating fixation device, the inguinal will be lesser. So in one arm, we use the self-fixating mesh, which comes in the name of ProGrip, and we just fix it to the to the place after space is created. And in the second arm, we just used the tack fixations, and the fixation was done at the Cooper's ligament at 2 points and 1 point, sometimes laterally. So at least two fixation devices, two fixations were used. We went through the IAC of our institute, and then we went to register it prospectively in the clinicaltrial.gov.in. We went for a computer-generated block randomization. The allocation was concealed well, and both the evaluator and the patients were blinded to the study. So we wanted to study the early postoperative pain using the VAS score and the quality of life using the Carolina Comfort Scale. We also studied the postoperative complications, the mesh deployment time, how long we are taking to deploy the meshes, the inflammatory response, although the inflammatory response part of the study could not be done because of the COVID coming in. So we excluded that for analysis. So the primary outcome measures were pain at different point in time, starting from 1 hour to up to 3 months, and same quality of life in the same time periods. The secondary outcome were to see the operative duration, mesh deployment time, and the incidence complications. Going with the 80% power and alpha of 5%, we had a sample size of 56 in each arm, total of 112. We included all unilateral hernias more than 18 years of age with the ASA2 who were fit for GA. We excluded the large total hernia, the complicated hernias, and patients of morbid obesity, and if there was a previous pelvic surgery. So on the whole, we could assess 143 patients, of which we could randomize 112, 56 in each arm. But one patient developed appendicitis, one had a suspicious recurrence. So 4 were excluded in the Tacker's arm, and 2 were excluded in the self-fixating arm because of lack of follow-up. So the basic baseline characteristics all similar in both the groups, as you can see, regarding the type of hernia, it was all similar. The comorbidities, be it diabetes, be it constipation, alcohol consumption, whatever, it was all similar in both the arms. So if you can see the operative duration, it is similar in both the arms. So even though it was a new mesh we are using and it was a little difficult to put it, the operative duration was rather lesser, but although it is not statistically significant. The peritoneal injury was higher in the ProGrip arm or the self-fixating arm. The learning curve, if you see, we started off with nearly 20 minutes to deploy the mesh, the ProGrip mesh, but by the end of the study, we actually were faster with the self-fixating mesh. Coming to the VAS scores, it's all similar at whatever given point of time we have studied that. And the same is vouched by the analytic use, which was on demand. The quality of life was similar in both arms with no statistical difference in either of the arms. If you see the complication rate, it is only the seroma and the cord edema were different, but again, it's not statistically significant. The strength of the study was that it was done by a single surgeon, so that we were actually doing it in a person who was really well versed with the thing. It is a well-designed, meticulously randomized controlled trial. The learning curve in a self-gripping mesh was studied for the first time. And this cohort of studies will be used for the recurrence rate. Very soon, we'll be doing that part of the study as well. The weaknesses being, it is a small sample size. The comparator was a polyester mesh we are using, not a polypropylene, which is more commonly used. But we chose this one because anyway, the polyester mesh was there in the ProGrip mesh. So the fixation was used in all cases, irrespective of the size of the hernia, as was not recommended by the Hernia Society guidelines. But here on one arm, we are using a self-fixating mesh. So we could not have compared a non-fixating mesh, so we used fixation on the other arm. And the cost-benefit analysis was not done, assuming because we are anyway not using the tacker, so obviously it will be cheaper in the other arm. So just to conclude, there was no statistical difference in between the early postoperative, which was the primary objective. The early postoperative pain was similar in both the arms. There were comparative postoperative outcomes as far as the learning curve, the avoidance of the fixation, and of course the pain also was concerned. Mesh fixation was definitely a merit because in this particular case, we can fix the mesh below the iliopelvic tract like we use in a glue. Longer follow-up and larger sample size study would be important to have bigger conclusions in this particular study. Thank you. I'm open to any questions.
Thank you very much. My question is, what were you using before you did the study, and what are you using in your practice now after the
Yeah.
study?
So it's a very nice question. Thank you for the question. So we would always use a polypropylene mesh with tack fixation. But once we were very well versed with doing a pro grip mesh or a self gripping mesh, my first choice is to go for the self gripping mesh. But that's not the case with my fellow faculty members who do not use it regularly. So this has a learning curve. And once we get over it, and in my case, it was as early as 14 cases, I was almost at par with the others. So for first 14 places, I struggled. In fact, the first case I did, I converted to open. So beyond that, it is all similar. So program, my first go-to mesh is the program mesh.
Thank you very much. It's nice to see an RCT data coming from India. One of the first papers in 2007 was Olmi et al. Showed unequivocally tack fixation increased pain. It's been repeatedly shown that tack fixation gives you increased pain in the groin, all systematic reviews and all of the randomized controlled trials. What makes your study different? Why did you not show? Where are you where are you placing the tacks? Are you more adherent to the anatomy in terms of triangle of pain? And is there any advice you can give to those surgeons that continue to use tacks based on your results, which are against the grain? They're different to all the randomized data.
Thank you for the question. It's a very, very nice question. I have to say that. So two things I like to say. First, the first part of the question, where do we fix it? We fixed 2 on the corpus ligament, making sure we are not going to the bone. 1 laterally. It's always above the iliopelvic tract. So that is not in all cases we use, but yes, mostly we did. So these are the 3 fixations what we used. Now, as far as actually why it's not similar to the other studies, because as you rightly said, most systematic reviews say that penetrating thing, even the Danish study said the penetrating meshes, the fixations are always a problematic thing. So I have to say the study, what we have done is still till 3 months. The longer aspect of the study is yet to be done, the recurrence and the longer postoperative pain we are going to study very soon. So by the next time, maybe I'll be presenting that. So maybe if I do that, I have different results. Early postoperative pain till 3 months, it's all the same.
Thank you very much.
Thank you so much.
All right, last but not least, we have Dr. Nisha Kapani presenting robotic repair of post-transplant incisional hernias, outcomes in complex hernia management.
Good morning, everyone. My name is Nisha Kapani, and I'm joined by my colleagues from Creighton University and Dignity Health St. Joseph's Hospital and Medical Center. Today, I'll be discussing our experience with robotic repair of post-transplant incisional hernias, specifically focusing on outcomes in complex hernia management. Incisional hernias are common and a challenging problem following transplantation. After liver transplantation, the incidence has been reported as high as 43%, and following kidney transplantation, as high as 20%. These hernias are typically large lateral defects, often exceeding 100 square centimeters, and patients commonly present with multiple comorbidities. Because of this, recurrence rates can be as high as 30%, making this a very difficult patient population to manage. Traditionally, both open and laparoscopic approaches have been used. The literature shows no significant differences between the two when it comes to infection rates, recurrence, complications, or length of stay. That being said, robotic surgery offers some unique technical advantages that we believe can improve outcomes in these complex repairs. There are several risk factors that predispose patients to post-transplant hernias. These include being overweight, having diabetes, episodes of acute rejection, pulmonary comorbidities, lymphoceles, and prolonged length of hospital stay. Interestingly, there's no clear association with immunosuppression itself. All these factors together create a patient population that can be both medically fragile and surgically complex. What makes these hernias especially challenging to repair is their location and anatomy. They often occur near bony structures, and there is an added complexity of muscle atrophy from denervation. Reconstructive planes are limited, which means that repairs require careful preoperative planning and advanced technical skill. This is where robotic surgery can play an important role. In our study, we performed a retrospective chart review of 24 patients who underwent robotic post-transplant lateral hernia repair at the Dignity Health Hernia Institute between 2019 and 2022. All patients underwent preoperative rehabilitation and imaging-based surgical planning, which we consider essential in this patient population. The most common location was in the flank. Our approach primarily used the transversus abdominis release, or commonly known as the TAR technique, which allows for excellent exposure and helps facilitate placements of large mesh. This is especially valuable in lateral hernias. We tailored the mesh size to the defect, with an average area of over 500 square centimeters. Here's our data that showed that all our post-transplant incisional hernias were some variation of a lateral or flank hernia. Of the 24 patients, 8 presented with recurrent hernias, which is about 1/3 of our patient group. The average defect width was 6.5 centimeters, with mesh sizes just averaging over 500 square centimeters. This data further depicts how large and complex these defects were. TAR was performed in 20 of the 24 patients, which is 83%. We also repaired some concomitant hernias, including midline, incisional, and umbilical hernias, each in 3 patients. Importantly, there were no conversions to open surgery and no intraoperative complications. This further demonstrates the feasibility and safety of the robotic approach. Postoperatively, the median length of stay was just 2 days. Only 1 patient required an emergency department visit for an AKI and C. diff. Early clinical complications were minor. 3 patients had urinary retention and 3 required supplemental oxygenation. Notably, there were no severe complications and no readmissions. While we saw a few seromas and hematomas, we did not see any surgical site infections or wound-related complications in this group. At a median follow-up of about 11 months, our patients have remained stable and with no hernia recurrences reported in this cohort. There are some limitations to our study. The sample size is relatively small of just 24 patients. Our follow-up duration is limited, and the low number of events means we couldn't perform a meaningful statistical analysis. So while our results are very encouraging, they should be interpreted with some caution. To conclude, a robotic repair of post-transplant incisional hernias is a safe and effective option. It offers low complication rates, short hospital stays, and in our experience, no recurrences to date. The TAR technique in particular enhances dexterity and exposure, which is especially beneficial in lateral hernia repairs. We believe these complex cases are best performed by experienced surgeons in specialized centers. Thank you so much for your attention. I'd be happy to take any questions.
Can you hear me?
Yes.
Thank you for this talk. When operating on patients with organ transplant, everything needs to be targeted to assure you have the least risk of injuring the organ, whether it's to the surgery or the technique itself. It should be a never event. Should never do a technique that has a risk of injuring the organ. I believe in your study you have no organ injuries and no transplant has failed after the hernia repair.
That is correct.
My concern is intra-abdominal approaches to patients with liver transplants, kidney transplants, and others puts that organ at risk in maybe a surgeon's hand that it may not be as skilled as your surgeons. So what are your thoughts on that?
Thank you for your question. I completely understand that sentiment, and that is also why we believe that these should be performed in specialized centers by specialized hernia surgeons.
Thank you very much. Nice to see some publications coming from Arizona. You have enough data there because you've shown I'm a liver surgeon and I dealt with all of these when I did liver transplantation. They're difficult patients. As Dr. Taufi said, there is a higher risk, immunosuppressed, mesh, pain, extrication, and infection. But you've shown really good results. But the only way to show the world what you've done is to do a match propensity study. So my question is, what was the standard procedure before the robot came? And do you have enough numbers to do a match study? Because you've got a big transplant unit.
In terms of enough numbers, I'm sure with some more time collecting data, we'll probably get there at some point with
Historically, what was done before the robot?
before here. I can't speak to that as I'm just a resident, but from my time on service, we only approach this robotically.
Yeah, and I'm helping your senior, your colleague. So if you know what was done historically, a match propensity study is what we need. And I'm pretty sure you have that data.
Yeah, I mean, prior to me going there, most of this was, I assume, performed by general surgeons there. I assume it was performed open in a number of different ways that currently aren't within the confines of our red cap that we're collecting. Yeah.
Thank you very much.
And regarding the safety of the organ, again, these are very complex hernias to be able to match, but with an extraperitoneal approach, you're actually staying above the liver. Like I'm not dissecting the liver, I'm not touching the liver. So whenever I do a transplant patient, I tell them my first priority is to keep you safe. The second priority is to keep your graft safe, whether it's kidney or liver. You know, we do a lot of kidney transplant hernias there. The third is to be able to give you the best repair possible. So, yeah. With a what? Meaning open. Yeah, I mean theoretically. There's any laparoscopic procedure has potential for injuring something. So again, typically these liver transplant patients, because of the immunosuppression, they typically don't have much adhesions despite all their multiple surgeries that they've had. So that's one thing that I've noticed. And yeah, we don't touch liver. So you know, you saw no conversions. I really try to stay minimally invasive with these transplant surgeons because they're on immunosuppression. So to avoid the big open operation, I think makes a lot of sense. But obviously, just like what Dr. Kapani was saying, if it's not a specialized center, that may be at risk.
Thank you very much. Thank you. And thank you to everyone for participating in our session. This was really awesome. And we will see you back here soon for the My Resident and I videos.